Hi, I'm Larry Green, and I'm proud to be hosting this presentation on vision screening programs. Proud because the information contained on this tape reflects tremendous work and tremendous commitment to the health and potential of our young people, Colorado's school children. The collective expertise contributing to this presentation includes ophthalmologists, optometrists, school-registered nurses, education and health administrators, members of the Colorado School Vision Screening Interdisciplinary Task Force, who met for over a year to develop these guidelines. Our public schools offer an excellent venue to promote preventive health care. Health screening is designed for early identification and diagnosis of disease and functional disorders. If school nurses, teachers, health aides, and other personnel can identify a potentially handicapping condition before it becomes symptomatic, then diagnosis and treatment can be undertaken at the optimum time and may decrease the cost of treatment. The screening is to be an easy, relatively inexpensive way to identify from a large number of apparently well people those who may be at risk of having a potentially handicapping condition. Vision is one of the 5 senses and primary to learning. Good vision is essential in the educational process. Vision screening for school children is not only good preventive care, it's mandated by law in Colorado. In this presentation, we'll explain and illustrate each procedure so that you'll be able to establish and administer an effective vision screening program in your own school. First, some terms. Screening. When we discuss screening in this tape, we're simply referring to gathering data on a population, the children in your school, for example. A screening program, however, uses this collected information as a basis to refer students with potential vision problems to an eye doctor for evaluation and treatment. The goal of a vision screening program is the detection of a potential problem and then the completion of successful intervention. Easy for me to say, you might be thinking at this moment. In fact, I understand the ramifications on your workload, and I hope this presentation will simplify the process of instituting the recommended vision screening program. As a result of serving as narrator on this tape, I have spent significant time trying to understand the job dimensions of a school nurse. I am impressed by the scope of your responsibilities. This recommended vision screening program seems like it could be enormously challenging. The screening room, for example, needs to meet appropriate specifications. You may need to involve other school personnel. Intervention may depend upon coordinating with an eye doctor. This tape is designed to help you understand the mechanics of setting up a screening program. Obtaining the necessary equipment, training and delegating appropriate responsibilities to others, administering certain procedures yourself, understanding the pass referral criteria, and then following up. Who gets screened? All students in preschool, kindergarten, 1st, 2nd, 3rd, 5th, 7th, and 9th grades. In addition, all children new to the school system, all children referred by school personnel or parents, and all students in special education programs should be screened annually. High-risk children, including those who repeat a grade and those who fail vision screening during the previous school year and did not receive further evaluation, should be screened. A child who fails any screening procedure should be referred for a second screening. This second screening must always be administered by a school-registered nurse or well-trained paraprofessional. If the child fails this second screening, the school nurse refers the child to an eye doctor and then follows up to ensure that the child did receive appropriate care. First, a brief description of the 7 tests. The first procedure is a system of ongoing observations of all students to be conducted by their teachers. The purpose is to detect any signs of obvious visual abnormalities. The second tests clearness of vision at distance, called the Distance Visual Acuity Procedure. Through this test, problems associated with nearsightedness, myopia, amblyopia, astigmatism, and other causes of visual loss may be identified. The third, the plus lens test, identifies greater than normal amounts of hyperopia, farsightedness. Fourth, the near point of convergence test screens for eye muscle coordination for near tasks. Potential misalignment of the eyes may be determined through the 5th procedure, the alternate cover test. Sixth, is the stereo depth perception procedure to test for binocularity. Finally, the seventh test identifies any deficiency in the ability to recognize colors. Proper procedures and referral criteria for each of these tests will be covered in detail and are also described in your guidelines manual. Some equipment will be necessary. A distance Snellen chart with a 20/25 line is used for the distance visual acuity and the plus lens tests. You will also need an occluder and a plus 250 diopter lens for the plus lens test. The occluder is used again for the alternate cover test. For the near point of convergence test, you will need a small handheld fixation target, the eraser end of a pencil, or a finger puppet may be used. For the stereo depth perception procedure, you'll need polarized glasses and a polarized stereo depth test. To test color, pseudo-isochromatic or isochromatic plates and normal lighting are needed. The total required equipment should cost less than $200. Recommendations for equipment suppliers may be found in the appendix of your manual. To begin the program, secure a room with subdued or adjustable light and one that allows for a 10 or 20-foot testing area. A large room may be used for mass screening with different stations for each screening procedure. Most tests may be administered by any trained screener. 2 tests require more in-depth training and experience and therefore must be administered by the school-registered nurse or well-trained allied healthcare worker. This chart lists the 7 recommended tests and the training requirements for each procedure. In the next section of the tape, we will explain and demonstrate each test that it may be performed or taught to others when appropriate. Again, any rescreening must be completed by the school-registered nurse prior to issuing a referral for a professional eye examination. The first procedure screens for possible abnormalities which can be detected by history or observing the child and then noted by any or all school personnel or the child's family. Distribute to teachers a list of symptoms or student complaints that might indicate a vision problem. Samples of in-depth lists can be found in your manual. This list might also be printed in a newsletter to go home to parents. Circulate the short ABC checklist, also found in your manual, to teachers and aides the day before screening and explain how to use this checklist. A in the ABC checklist is for appearance. Do a child's eyes look normal? B for behavior. Observations by teachers and parents. C, complaints from the child. Sample short forms in English and Spanish are also in your guidelines manual. In addition, this short form might be used by a screener during the actual procedures. A referral to an eye doctor must be made if a student has any symptoms listed, even if the student passes all other screening tests. The second test is distance visual acuity to detect nearsightedness, amblyopia, and astigmatism, and can be administered by any trained screener. You will need the distance Snellen chart, which includes a 20/25 line, occluder, or paper cup, or patches to cover first one eye and then the other, and a marked 20-foot distance from the chart. This test can be adjusted for a 10-foot distance. The Snellen chart is a series of letters, symbols, or numbers of decreasing size. The resulting ratio expresses visual acuity. The numerator, the number on the top of the fraction, is the distance at which the test was given, 20 feet. The denominator, the lower number, is the distance at which a person with standard visual acuity can see the chart symbols. 20/20 represents this standard visual acuity. Select a room for testing that has subdued lighting but is not dark. The Snellen chart must be in good lighting with no glare on the chart surface. Mark off 20 feet from the eye chart and have the child sit or stand on this line. Hang the chart at the student's eye level. Cover the left eye with an occluder, a card or cone-shaped cup. Tell the student to keep both eyes open and have the student read the letter on the chart to which you are pointing. Point just under the line that you're asking the student to read. Finish testing the right eye and then cover the right eye to test the left. Students who wear glasses should keep them on unless the student says that sight is better without them, or that the glasses are only to be worn for reading. In that instance, test both with and without glasses. Start with the 20/40 line or above and ask the student to read that line and move down to the 20/20 line. If a student is unable to read the 20/40 line, move upward. If a student cannot read more than half of the symbols on a line, point to the line above and ask the student to read that one until visual acuity is established. Record the line number for the last line read correctly with each eye. Each eye must see the 20/30 line or better. If not, the student fails and is referred for a second screening. The important exception is a two-line difference between the two eyes, such as the right eye sees 20/20 and the other eye sees 20/30. Individually, each eye would pass, but as indicated by the two-line difference on the recording chart, the child fails since there is a two-line difference between the acuity of each eye. Do not allow students to squint during the test or overhear others reading the chart. For younger children, use the Snellen E or HVOT chart. Play the E game on the specialized Snellen chart for preschoolers in the classroom before the actual testing. This is an E. See which way the E is pointing? Show me with your fingers how the E is pointing. With young children, have them use their arms rather than fingers to indicate which way the E is pointing. The third test is the plus lens test. It determines greater than normal amounts of farsightedness and can be administered by any trained screener. Preschool children or kindergartners do not need to be included in this procedure. You will need the distance Snellen chart, occluders, and a plus 250 diopter lens, either as a flipper or glasses. Proceed like the test for distance visual acuity. Select a room for testing that is subdued lighting but is not dark. The Snellen chart must be well lit with no glare. Mark off 20 feet from the eye chart and have the child sit or stand on this line. Hang the chart at eye level with the student. Cover the left eye with an occluder, a card, or cone-shaped cup. Tell the student to keep both eyes open and have the student read the letter on the chart to which you are pointing. Finish testing the right eye and then cover the right eye to test the left. Students who wear glasses should keep them on unless the student says that sight is better without them or that the glasses are only to be worn for reading. In that instance, test both with and without glasses. If the student can read the 20/30 line or better through the plus lens with either eye, it indicates failure because of excessive hyperopia. A referral for second screening should be made. To pass the plus lens screening, the student should not be able to read the 20/30 line or better. For example, the 20/25 line or 20/20 line. Failure in one eye or both should generate a referral. This fourth test, near point of convergence, checks eye muscle coordination for near tasks. It requires the training and experience of the school-registered nurse or well-trained allied healthcare worker. To conduct the test, you will need a small handheld target like the eraser end of a pencil or a finger puppet. Hold the fixation target 20 inches from the child's face. Instruct the child to look at the target as you move it slowly toward the child's nose. Ask the child to report if the target breaks into two images. As you move the target toward the child's nose, watch both eyes. If one eye stops converging or moving in, the child should report seeing two images, and you will see one eye wander outward. If neither eye turns out, record 0 or TN for to nose. Not all children will report double vision at the break point, so your observation is important. Record in inches how far the target is from the bridge of the nose when you no longer see the eyes converging. Repeat this test several times to ensure that the child just didn't look away at that moment. The eyes should be able to converge to at least 6 inches from the bridge of the nose. If not, the child should be retested and then referred to an eye care professional. This fifth test, the alternate cover test, should also be conducted by the school-registered nurse or by a well-trained allied healthcare professional. The purpose of this test is to determine potential eye misalignment and detect strabismus or heterophoria. You will need an occluder and fixation target such as a picture or poster at a distance of 10 to 20 feet. Use a 10-foot chart for younger children to help them maintain concentration. Instruct each student to watch a specific target. You need to observe the students at their eye level. Students who wear glasses should keep them on for this test. First, cover the right eye and watch to see if the right eye moves at all to resume looking at the target when the occluder is quickly moved from the right eye to cover the left. Then, verify the movement by watching the left eye for movement when the occluder is moved to the right eye. Repeat this process several times. Move the occluder fairly quickly when switching from one eye to the other, so both eyes aren't allowed to view the target simultaneously. Any consistent horizontal, vertical, or diagonal movement of the uncovered eye while the student is fixed on the target should generate a referral. The stereo depth perception test, which is the 6th procedure, can be administered by any trained screener. It tests for binocularity. You will need polarized glasses and a polarized depth test picture, such as the stereo fly, the stereo reindeer, or RANDOT. With the polarized glasses on, show the child the large picture of the fly or reindeer to demonstrate the upward flow to the picture. Ask the child to pinch the wings or antlers as demonstrated, guiding the child's hand in from the side. Children without depth perception will touch the page rather than experience the image in 3D. Refer students if the picture is not seen in depth. In the RANDOT picture, older students can be asked which of the numbered circles is floating toward them. Make sure there is no glare on the test sheet. Students should be able to identify the correct response in at least 5 of the numbered circles. The 7th and final test in this vision screening program identifies any discrepancy in the ability to recognize color. Any trained screener can administer this test. Screen first graders, teacher referrals, special education, and new students who have not previously been screened. You will need pseudo-isochromatic or isochromatic plates for testing and a normally lit room. Show students how to use the dry paintbrush or cotton-tipped swab to trace the symbols on the color plate. Do not use fingers or pencils to trace the lines, as it can cause color change of the plates. Failure in this test is not a cause for referral, but teachers and parents should be notified so that color vision deficiencies can be taken into consideration in situations where color discrimination is necessary. These are the 7 procedures that comprise the testing phase of a vision screening program. You will be collecting and analyzing a lot of data on each child tested. It is important to be familiar with the pass referral criteria so that you can act expediently in following up with those children who need to be rescreened and then referred to an eye doctor when necessary. Let's review the referral process. The school nurse administers and supervises the entire screening program. All failures or concerns should be referred to the school nurse for rescreening within 30 days following the initial failure. If a child fails the rescreening, the school registered nurse should sign a written referral form and send it to the child's parents or guardian within 14 days following the second vision screening. Note that the referral form includes space for the results of the professional eye examination, the eye doctor recommendations, and any necessary prescriptions. Teachers must also be notified in writing or given a list of students who have been referred for further vision evaluation. If the student has not received care within 2 months, the school nurse must follow up in writing and by telephone. There are 10 important steps that the Colorado Department of Health recommends for vision screening follow-up. They are listed in your guidelines manual and include what kinds of steps to take if a child does not receive appropriate professional follow-up care through the family or guardian. Also in the manual are sample report worksheets and sample referral forms. The 7-test screening program we covered in this tape should be conducted in the first semester each year. But if your district screens year-round, screen individual grades at the same time each year. A vision screening program is a critical preventive health measure. It's important to all school children. This presentation is designed to make it easier for you to understand the specifics of each procedure, pass-fail criteria, and the referral follow-up process. Thank you for your attention and your commitment to school children's ongoing care. This final graphic repeats just once again the vision screening summary, the tests, and the referral criteria.